I'm Dr. Michael Patterson, and I've been a cardiac surgeon at Riverside Medical Center in Charleston, West Virginia for 18 years. Or at least I was until I submitted my resignation last month. During my career, I've performed over 3,000 heart surgeries, witnessed countless miracles of modern medicine, and saved lives that seemed beyond saving. But what I'm about to tell you about is the one case that made me question everything I thought I knew about life, death, and the very nature of human existence. Riverside Medical Center is a Level 1 trauma facility serving the tri-state area of West Virginia, Ohio, and Kentucky. As the chief of cardiac surgery, I've seen every kind of heart condition imaginable: massive heart attacks, complex congenital defects, traumatic injuries, and cases where patients arrived essentially dead and walked out weeks later completely restored. The case that changed everything began on a cold February evening in 2023. I was finishing up my rounds when my pager buzzed at 11:47 p.m. The message was from Dr. Sarah Chen, the emergency department attending. Code Blue, cardiac arrest, incoming trauma, ETA 12 minutes. Need you in Oregon 3 immediately. I made my way quickly to the cardiac surgical suite where my team was already preparing. My surgical technician, James Rivera, had worked with me for over a decade. My anesthesiologist, Dr. Patricia Williams, was one of the most experienced in the state. If anyone could handle whatever was coming through those doors, it was this team. The paramedics wheeled in Anthony Yahle, a 37-year-old construction supervisor from Bellbrook, Ohio. His wife had found him in their bedroom that morning at approximately 4 a.m., breathing abnormally and completely unresponsive. When she couldn't wake him, she called 911. The paramedics had managed to establish a faint pulse during transport, but Anthony's condition was critical. His blood pressure was barely detectable, his skin had a grayish pallor, and his heart rhythm was chaotic. We immediately began aggressive resuscitation efforts. "What's his downtime?" I asked the lead paramedic as we transferred Anthony to the OR table. Family estimates he was down for at least 20 minutes before they found him. We got a pulse back after 15 minutes of CPR, but it's been touch and go the whole way here. That was not encouraging. After 20 minutes without circulation, most patients suffer irreversible brain damage, but I've learned never to give up too early. The human body can surprise you. We worked on Anthony for the next 4 hours. His heart would stabilize briefly, then crash again. We administered every medication in our protocol, shocked his heart multiple times, and even considered emergency bypass surgery. But each intervention provided only temporary improvement. Dr. Williams monitored his vitals constantly. "Michael, his pupils are fixed and dilated. No corneal reflexes. I'm not getting any response to pain stimuli." I checked his pulse myself. Nothing. The monitors showed a flat line. His skin was cold to the touch, and rigor mortis was beginning to set in around his jaw. At 4:17 a.m., after exhausting every possible intervention, I made the call that no surgeon wants to make. Time of death, 4:17 a.m. We had followed every protocol. Anthony showed no signs of brain activity, cardiac function, or respiratory effort. His body temperature had dropped to 94 degrees Fahrenheit despite our warming efforts. According to every medical standard I knew, Anthony Yahle was dead. I stepped outside to speak with his family. His wife, Linda, was in the waiting room with their teenage son. This is always the hardest part of my job. I sat down across from them and delivered the news that no family should ever have to hear. "I'm very sorry," I said gently. "We did everything we could, but Anthony didn't make it." His heart stopped, and despite our best efforts, we weren't able to bring him back. Linda collapsed into her son's arms. The sound of her grief filled the waiting room. After giving them some time, I explained that they could see him to say their goodbyes, and that we would need to discuss arrangements with the funeral home. What happened next defies every principle of medicine I learned in medical school. At approximately 5:30 a.m., I was in my office completing Anthony's death certificate when James burst through the door, his face white with shock. "Dr. Patterson, You need to get to OR3 immediately. There's something wrong with the monitors." "What do you mean wrong?" "The cardiac monitor. It's showing a heartbeat, a strong one." I looked at him like he was crazy. "James, we disconnected him from the monitors over an hour ago. Did you check the leads?" "Sir, that's the thing. We never disconnected him. We were waiting for the family to come say goodbye and the monitor just started beeping." I ran to OR3, convinced there had to be a technical malfunction. What I found there challenged everything I understood about the boundary between life and death. Anthony Yahle was sitting up on the surgical table, fully conscious, looking around the room with clear, alert eyes. "Where am I?" he asked, his voice hoarse but perfectly coherent. "What happened to me?" I stood frozen in the doorway, unable to process what I was seeing. This was medically impossible. I had personally verified his death 75 minutes earlier. No pulse, no brain activity, body temperature dropping, and early rigor mortis. He had been dead by every medical definition I knew. Dr. Williams, who had also rushed back to the OR, was checking his vital signs with trembling hands. Blood pressure 110/70, heart rate 78, oxygen saturation 98%, temperature 98.6 degrees Fahrenheit. All normal ranges. "How long was I out?" Anthony asked, sitting up further and swinging his legs over the side of the table. I approached him slowly, still unable to believe what I was witnessing. "Anthony, do you remember what happened to you?" He thought for a moment, his brow furrowed in concentration. "I remember feeling really sick yesterday. Really sick. Like I couldn't breathe. Linda called 911 and there were paramedics in our bedroom. Then, nothing, until just now. I performed a neurological assessment. His reflexes were normal. His memory of events leading up to his collapse was intact. His speech was clear, his reasoning sound. There was absolutely no indication that he had been clinically dead for over an hour." "Anthony, I need to be completely honest with you. You were declared dead at 4:17 this morning. That was over an hour ago. Your heart had stopped, you had no brain activity, and your body temperature had dropped significantly." He stared at me with those clear blue eyes, processing this information with remarkable calm. "Dead? Like, actually dead?" "By every medical standard I know, yes, you were dead. But I'm here now," he said simply. "I feel fine. Actually, I feel better than I have in weeks." I couldn't argue with that logic, but I also couldn't explain what had happened. I immediately ordered a full battery of tests: EKG, echocardiogram, blood work, CT scans of his brain and chest, and an MRI. If Anthony had somehow survived what appeared to be death, I needed to understand how and why. Dr. Chen arrived within minutes of receiving my call. As the emergency department attending who had first treated Anthony, she needed to see this for herself. "This is impossible," she said, reviewing the timeline. "I was here when you called the time of death. I saw the flat line. I witnessed the absence of vital signs." "I know how it sounds," I replied. "But he's sitting right there, talking to us, completely lucid." The test results came back normal. Better than normal, actually. Anthony's heart function appeared optimal. His brain scan showed no signs of hypoxic injury. His blood work indicated perfect organ function. There was no medical explanation for his revival. Word of Anthony's case spread quickly through the hospital. Within hours, colleagues from cardiology, neurology, emergency medicine, and hospital administration were asking questions. How does someone come back from clinical death? What had we missed in our initial assessment? Dr. Robert Steinberg, our chief of neurology, examined Anthony extensively. "I've been practicing for 30 years, he told me privately. "I've never seen brain function this intact after prolonged cardiac arrest. There should be significant neurological deficits, memory loss, coordination problems, and cognitive impairment. He shows none of that." The hospital's ethics committee convened an emergency meeting to discuss the case. Medical examiners from the state health department were contacted. Everyone wanted to understand how we had missed signs of life in our initial assessment, but I knew we hadn't missed anything. I had checked for pulse myself multiple times. I had confirmed the absence of breathing, the lack of corneal reflexes, and the fixed and dilated pupils. Anthony Yahle had been dead, and then he wasn't. As news of Anthony's case began to circulate in medical circles, I started receiving calls from colleagues around the country who had witnessed similar phenomena. Dr. Lisa Martinez from Cedars-Sinai told me about a patient who had been declared dead for 23 minutes before spontaneously returning to life. Dr. James Thompson from Johns Hopkins described a case where a woman had been clinically dead for 3 hours. I began researching what's known in medical literature as Lazarus syndrome, or auto-resuscitation after failed cardiopulmonary resuscitation. The phenomenon was first described in medical journals in 1982, but cases are extremely rare and poorly understood. The most documented case I found was that of Velma Thomas, a 59-year-old woman from West Virginia who had been declared clinically dead for 17 hours. Her family had already begun making funeral arrangements when she suddenly revived. Like Anthony, she made a complete recovery with no neurological deficits. What troubled me most about these cases wasn't just their medical impossibility, but the consistent pattern of complete recovery. These patients didn't return as vegetables or with significant brain damage. They came back fully intact, often reporting feeling better than they had before their death. Anthony remained in the hospital for observation for 72 hours. During that time, I spent considerable time talking with him, trying to understand his experience during the period when he was clinically dead. "Do you remember anything from when you were unconscious?" I asked him during one of our conversations. He was quiet for a long moment, staring out the hospital window. "This is going to sound crazy." At this point, nothing sounds crazy to me. I remember floating above the room. I could see you working on me. I could see Linda crying in the waiting room. I wanted to tell her I was okay, but I couldn't. This was consistent with near-death experiences reported by other Lazarus syndrome patients. But what made Anthony's case different was the duration. He had been clinically dead for 75 minutes, far longer than most reported cases. "I saw a bright light," he continued, "and I had a choice. I could go toward it, or I could come back. I thought about Linda and our son, and I chose to come back." "What made you choose that moment to return?" I heard Linda's voice. She was talking to me, even though the doctors had told her I was gone. She was telling me about our son's upcoming graduation, about the trip we had planned for our anniversary. She said she wasn't ready to let me go. I checked the timeline. Linda had been in Anthony's room talking to his body at approximately 5:25 a.m. The monitors had shown his first heartbeat at 5:32 a.m. Anthony's recovery was complete and rapid. Within 48 hours, all his vital signs had normalized. His cardiac function was better than it had been in years. Neurological tests showed no deficits whatsoever. It was as if his period of clinical death had somehow reset his entire system. "I've never felt this good," he told me before his discharge. "It's like I got a second chance, and my body knows it." This raised disturbing questions about our understanding of death itself. If Anthony could be clinically dead for over an hour and then return with perfect function, what does that say about our definition of death? How many people have we declared dead who might have recovered if we had waited longer? The hospital's legal department was concerned about liability issues. Had we made an error in declaring Anthony dead? Could families of other patients claim we had given up too early? But I knew we had followed proper protocols. Anthony had met every clinical criterion for death. The fact that he had somehow returned didn't change that. Anthony returned home after 3 days in the hospital. I saw him for follow-up appointments at 1 week, 1 month, 3 months, and 6 months after his incident. His recovery remained complete. His heart function continued to be excellent. He had returned to work and was living a completely normal life. But the case continued to haunt me. I found myself second-guessing every death declaration I made. When a patient flatlined, I waited longer before calling the time of death. I began ordering more extensive testing, looking for any sign of remaining brain activity. My colleagues noticed the change in my behavior. "Mike, you can't save everyone," Dr. Chen told me after I had worked on a cardiac arrest patient for 3 hours, past the point where most doctors would have stopped. "How do I know when to stop?" I asked her. "How do I know they're really gone?" "You follow the protocols. You use your medical judgment. That's all any of us can do." But Anthony's case had shattered my confidence in those protocols. If our medical judgment could be so completely wrong once, how could I trust it again? 6 months after Anthony's incident, we had another case that defied explanation. Walter Williams, a 78-year-old man from nearby Lexington, was brought in by his hospice nurse after she found him unresponsive in his home. He had been under hospice care for end-stage kidney disease. When the coroner arrived, he examined Walter and declared him dead at 9 p.m. The body was prepared for transport to the funeral home. I wasn't directly involved in this case, but I was called when something unprecedented happened. At 11:45 p.m., a funeral home employee called the hospital in a panic. Walter Williams had begun breathing during the embalming preparation. He was alive, conscious, and asking for water. Walter was rushed back to the hospital, where I examined him. Like Anthony, his vital signs were completely normal. His kidney function, which had been failing for months, showed remarkable improvement. He was alert, oriented, and showed no signs of the delirium often associated with end-stage kidney disease. "How do you feel, Mr. Williams?" I asked during his examination. "Better than I have in years, Doc. Is it true they thought I was dead?" "According to the documentation, yes. You were declared dead by the coroner at 9 p.m. Walter chuckled. "Well, that was premature." Walter's case convinced me that what we were witnessing was more than isolated medical anomalies. There was a pattern here, something that challenged our fundamental understanding of death and recovery. Both Anthony and Walter had made complete recoveries after being declared dead. Both reported feeling better than they had in years. Both had experienced what they described as near-death experiences during their periods of clinical death. I began documenting every detail of these cases, creating a comprehensive database of Lazarus syndrome incidents. What I found was disturbing and fascinating in equal measure. The medical literature contained references to at least 38 documented cases since 1982. The duration of clinical death ranged from minutes to hours. In every case where neurological testing was performed, patients showed no signs of brain damage despite prolonged periods without oxygen. Most troubling of all, the phenomenon appeared to be increasing in frequency. Whether this was due to better documentation, improved resuscitation techniques, or some other factor, I couldn't determine. As word of my interest in Lazarus syndrome spread, I began receiving calls from families around the country who believed their loved ones had been declared dead prematurely. Medical colleagues started questioning my judgment and competence. Hospital administration expressed concern about my obsession with these rare cases. "Michael, you're one of our best surgeons," Dr. Patricia Hendricks, the chief of staff, told me during a meeting in her office. "But your behavior lately has been concerning. You're keeping patients on life support long past the point where most doctors would discontinue care." "What if they could recover?" I asked. "What if we're giving up too early? You can't base medical decisions on 2 unusual cases. You know better than that." But I couldn't shake the feeling that we were missing something fundamental about the nature of death and recovery. How many patients had we lost because we followed standard protocols instead of waiting for the impossible? My relationships with colleagues became strained. My surgical schedule was quietly reduced. I found myself isolated in my own department, viewed as the doctor who had become too invested in unexplainable phenomena. The final case that convinced me to leave cardiac surgery occurred 8 months after Walter Williams. Velma Thomas, a 59-year-old woman from Nitro, West Virginia, suffered a massive heart attack at home. Her son found her unconscious and called 911. By the time paramedics arrived, Velma had been in cardiac arrest for an estimated 15 minutes. They managed to establish a weak pulse and transported her to our facility. I wasn't the primary surgeon on her case, but I was consulted when her condition deteriorated. Despite aggressive intervention, Velma's heart stopped twice more after arriving at the hospital. She was placed on life support while we attempted to stabilize her condition. Her brain showed no activity on EEG. Her body temperature dropped dangerously low despite warming measures. After 17 hours of intensive care with no signs of improvement, the family made the difficult decision to withdraw life support. Velma was declared clinically dead, and arrangements were made for organ donation. I was in surgery when it happened, but Dr. Williams called me immediately. "Michael, you need to get down here. Velma Thomas just woke up." I found Velma sitting up in her ICU bed, talking to her son. Her skin, which had been grayish and mottled, was pink and healthy. Her eyes were clear and focused. She was asking for something to eat. "How long was I out?" she asked me when I introduced myself. "Mrs. Thomas, you were clinically dead for 17 hours. We had removed you from life support and were preparing for organ donation." She absorbed this information with remarkable composure. 17 hours? That's a long time to be gone. What do you remember from that time? I remember seeing my late husband. He told me it wasn't my time yet, that I needed to come back to take care of our grandson. The next thing I knew, I was waking up here. Velma's recovery was as complete as Anthony's and Walter's had been. Within 24 hours, all her vital signs had normalized. Neurological testing showed no deficits. Her heart function was better than it had been before her initial attack. But the case was the final straw for me professionally. The hospital administration was concerned about liability. My colleagues were questioning my competence. Families of other patients were asking why their loved ones hadn't received the same miraculous treatment. I realized I could no longer practice cardiac surgery with confidence. How could I make life and death decisions when I no longer understood where the line between life and death actually lay? I submitted my resignation to Dr. Hendricks on a Tuesday morning in March 2024. "Michael, you don't have to do this," she said. "Take some time off. Maybe see someone to talk through what you've experienced." "Patricia, I've seen 3 people come back from clinical death, not near death, not almost dead, actually dead by every medical standard we have, and they all came back perfectly intact. That's not supposed to be possible. Medical anomalies happen, you know that. Not like this. Not with this consistency. There's something we don't understand about death, about consciousness, about what it means to be alive, and I can't keep making decisions based on incomplete knowledge." I left Riverside Medical Center and moved to a small town in rural Montana, where I now work as a family physician. I treat common ailments, manage chronic conditions, and avoid any cases that involve life and death decisions. But the 3 cases I witnessed continue to haunt me. Anthony Yahle, Walter Williams, and Velma Thomas were all declared dead using proper medical protocols. They all returned to life after significant periods of clinical death. They all made complete recoveries that defied medical explanation. What disturbs me most is the implications for all the patients we didn't wait for. How many people have we declared dead who might have returned if we had been more patient? How many families have we told their loved one was gone when they might have been experiencing something we don't yet understand? The medical establishment prefers to classify these cases as anomalies, rare events that don't warrant changing established protocols, but I can't dismiss what I witnessed. I held Anthony's wrist and felt no pulse. I watched the monitors flatline for 75 minutes. I signed his death certificate, and then he came back. Since leaving cardiac surgery, I've continued to research Lazarus syndrome. The cases are more common than most doctors realize, but they're often dismissed or not reported in medical literature. The phenomenon challenges our most basic assumptions about life, death, and consciousness. Some researchers theorize that the syndrome is caused by a buildup of pressure in the chest during CPR, which is suddenly released when resuscitation efforts stop, allowing circulation to resume. But this doesn't explain cases like Velma's, where the patient was declared dead 17 hours after CPR had ended. Others suggest that our methods for determining death are inadequate, that we're missing subtle signs of life that persist even when conventional vital signs are absent. But I performed those examinations myself. I know what death looks like, and these patients were dead. The most unsettling possibility is that consciousness and life exist in ways we don't yet understand. If Anthony could observe the room while clinically dead, if Walter could experience awareness during embalming preparation, if Velma could interact with deceased relatives during her 17 hours of death, what does that say about the nature of human consciousness? Anthony Yahle returned to his construction job and has had no medical issues since his incident. Walter Williams lived for 3 more healthy years before dying peacefully in his sleep in 2022. Velma Thomas continues to live independently and cares for her grandson, just as she was told to do during her near-death experience. All 3 have asked me the same question: why them? Why were they chosen to return when others aren't? I don't have an answer. What I do know is that witnessing these cases changed my understanding of medicine, of life, and of my own limitations as a physician. The heart that beat after death will haunt me for the rest of my life, not because it was terrifying, but because it revealed how little we truly understand about the mystery of human existence. Sometimes, late at night, I wonder how many other patients might return if we just waited a little longer. But that's a burden I can no longer carry in an operating room. Some questions are too big for one surgeon to answer, and some mysteries are too profound for current medical science to explain. The dead don't always stay dead, and sometimes that's the most haunting truth of all.